Well, good morning, everyone, and welcome to today's District Health Department number 10 Community Health Summit. Our purpose today is to kind of share with you some of the data that we have accumulated through the Community Health Needs Assessment or the MyThrive Community Health Needs Assessment that was completed in 2021, specifically looking at the 10 counties that make up the District Health Department number 10 jurisdiction. So this is going to be a tag team effort, and I'm going to do the first part here of kind of laying a little bit of a foundation in terms of how public health works and some background on public health, and then I'll turn it over to Donna and to Aaron to kind of present the local data tour, so to speak. So why don't we go ahead and move to the next slide, please. All right, this slide right here is titled Core Functions of Public Health. And so public health has continued to evolve in its operation and how it addresses issues within the community. And even though we have evolved to some extent, the core functions and the 10 essential services have remained pretty consistent in terms of kind of providing guidance to us as to how we move through all of this process. So all public health departments and all public health agencies really reference back to these. And you have the three core functions of local public health that are assessment, policy development, and assurance. And then under each of those core functions, you have what are referred to as the 10 essential services. So you'll see there's two of the essential services are under assessment, 4 under the policy development, and then 4 are under the assurances. Now in the middle there, you'll see it's where it references equity. And this is probably the one area that has changed over time. Originally, with regards to the core functions and 10 essential services, research is really what made up the middle area there. Now that we have evolved into what we're calling Public Health 3.0, and I'll talk a little bit more about that in a couple slides here, we're now focusing in on equity. So we've moved from research and into equity, again, trying to assure that regardless of who you are or where you live, everyone has an equal opportunity to being able to live and maintain a healthy life. So next slide, please. All right, Public Health 3.0. I made reference to this in the previous slide. You see there are 3 buckets, the traditional clinical prevention, the innovative clinical prevention, and then the total population or community-wide prevention. And these 3 buckets represent that evolution of public health services. So that traditional clinical prevention, or bucket number 1, is what we refer to as Public Health 1.0. And this was really focused in on the beginnings of public health and focusing in on disease prevention type efforts. So, some examples of things that would fall underneath that would be sanitation, clean drinking water or safe drinking water, and then vaccines or immunizations. The second bucket there, that innovative clinical prevention, references Public Health 2.0. And that area or that evolution occurred probably in the early 2000s and really began to focus not only on those what you might consider to be traditional services of the local public health department, but also kind of the next level. So kind of beginning to move into this area of policy systems and environmental change type work. And so examples of things would be all strategies that focus on healthy eating, on increasing physical activity, and the roles that both of those play on maintaining healthy lifestyles, and then also began then to focus in on some of the senior health areas. The third bucket there, the total population or community-wide prevention, is where we're at currently now, and this is referred to as Public Health 3.0. And this evolution occurred probably 2015, 2017, somewhere in that time frame. And again, this is where that idea of equity came about. And so the ultimate goal being to assure that whoever you are, regardless of where you live, everyone has an equal opportunity, or the same equal opportunity to living and maintaining a healthy lifestyle. And so within this idea of Public Health 3.0, there are some strategies or conditions that we try to meet, or that we work towards, and they're listed over on the left of the slide here. So again, you'll see health equity in the middle, and so the strategies that we look at or try to incorporate into using or achieving that is going to be, having public health seen as the chief health strategist. Now, this is not to mean that public health is going to be seen or should be seen as the solver of all of the problems in a community or in a county, but rather seen as the entity that is monitoring the health specific data. And when I say health specific data, I reference that in a broad sense. And then also serving in that role of bringing individuals together, a group of individuals together to develop strategies, and so that we can focus in on what the health problems are. So again, not to be the end-all problem solver, but rather that convener that is going to bring entities together to try and come up with strategies to solve those problems. When we talk about another strategy being enhanced and modified funding, this is probably, for us at least, is one of the most difficult ones to try and achieve in this notion of Public Health 3.0. The vast majority of funding that we receive as a public health agency is categorical funding, or it's funding that is targeted to specific areas. And so those areas could be food, they could be water, they could be wells, they could be septics, they could be communicable diseases. And while that's all well and good, those are not the only issues that we identify that are impacting the health of the community. And so this idea of enhanced and modified funding is really funding that is provided without strings attached to it in terms of what it needs to be used for. And so if we identify a specific issue in the community, having this enhanced or modified funding would allow us to actually implement strategies to try and address it. But again, this is going to be one of the more difficult ones to achieve through Public Health 3.0, and it's a struggle right now. Actionable data is the third strategy that we have there, and actionable data just refers to making sure that all the decisions we make on addressing a particular issue, whether that be in forming strategies or implementing those strategies, is based upon having good, accurate data. And so as a public health entity and being seen as that chief health strategist, one of the expectations or one of the roles for public health is that we are going to be, gathering that data. We're going to be assessing that data. We're going to be evaluating that data, and then putting that data out there and telling a story with that data, so that the group that we bring together can identify the strategies that they are going to work on. Public health accreditation is the fourth strategy here, and public health accreditation really references the credibility of the health department, or the credibility of being seen as that chief health strategist. Here in Michigan, we have two accreditation opportunities. We have what is referred to as our state accreditation. This is a mandated accreditation that all health departments have to go through. It's a 3-year process, and it's really necessary in order to meet this accreditation requirements in order to receive any funding from the state. So our state accreditation, probably the easiest way to think about it is it's really an assessment of the widgets that we're making. So it's how many immunizations are we providing, how many well permits are we providing, how many wells are we inspecting, and so on and so on. The other accreditation opportunity that we have is a voluntary accreditation, and that's referred to as National Public Health Accreditation. District Health Department number 10 is currently a nationally accredited health department. Actually, in Michigan, we were the third local health department to go through and be accredited at the national level. What national accreditation provides is there is an established set of standards and measures that all health departments, tribal, state, and local, can assess themselves against and compare themselves to other health departments, so that we can see where we stand with regards to providing the standards and measures. National public health accreditation, once achieved, is good for 5 years. Now, COVID has kind of put a little bit of a wrench into that process, and so we were first nationally accredited in 2015. In 2020, we were, supposed to be going through our reaccreditation process, but again, COVID has pushed that back. Our hope is that we'll have all of our documentation submitted so that we can be considered for national accreditation hopefully sometime by the end of August in 2022, and then we'll wait to hear if we have continued to achieve national public health accreditation. I have no doubt that we will continue to meet that. While it is a voluntary type of accreditation process, I feel there's quite a bit of value in being able to say we are a nationally accredited health department. It allows us to, as I said, compare ourselves to all of the other health departments as to where we stand. And so the difference between the state accreditation and the national accreditation, whereas the state accreditation is more of that, are you producing the widgets? National public health accreditation is really looking at the processes that you use to achieve those widgets. And so if you think back to those 3 core functions and 10 essential services, it's really evaluating how we measure up to those 3 core functions and 10 essential services. The last one, the fifth strategy or fifth factor, is this cross-sector collaboration. And so, part of being seen as that chief health strategist is also, being able to convene that group of partners to come together to address a problem or try to solve a problem. The cross-sector collaboration is referencing, not only including what you would consider those traditional healthcare partners, so the hospitals or the health systems or the providers, but also incorporating in some of those what may be considered non-traditional health partners. So the food banks, the transportation folks, the housing folks, so that you have a broad set of partners that come together to try and address a strategy. One of the problems probably with that is everybody kind of comes with their own agenda, and so as that chief health strategist, the struggle and the strategy is to kind of get everybody on the same page. And in trying to do this, we use a process that's referred to as collective impact, and I believe that is the next slide that we have. So collective impact is the process that we go through to try and address problems within a community. I'm sure many of you have heard this. It's a term that's been around for a while, but again, it is a process that we still continue to use. And within collective impact, again, there are a number of conditions or a number of factors that we look at. The first one being having that common agenda. And so again, getting everybody to be on the same page, regardless of whether or not you may come to the table with a different agenda, it's getting everybody on the same page that this is the problem that we have to address, and getting everyone to recognize that in addressing this problem, you do have a seat at the table. It may be difficult for you to see that, but hopefully through this process, you'll recognize that you do have a role to play in doing this. The second one is this idea of shared measurement. So again, it's getting everybody on board with these are the metrics or these are the measures that we need to monitor to assess how well we are doing in addressing that problem. So again, getting everybody on the same page, first with the agenda and then with the measures that we're going to use. The third strategy or third factor is going to be this mutually reinforcing activities. Now, this is not to say that every entity or every partner around the table is going to do the same activity, but rather that the activities that the partners are going to do are going to build upon what was previously done. So if the health department, as an example, is doing one strategy and the hospital then is going to do another strategy, the strategy that the hospital is going to do is going to build upon or enhance what the health department is doing, and the same thing, so on and so on and so on down the line. Again, all for the purpose of trying to address what we all recognize as being the issue in the community. This idea of number 4, this continuous communication, is pretty common sense. You want to make sure that everybody is aware on a regular basis of what's going on. So it's being transparent, and it's not keeping issues covered up, but rather this is where we're at, this is what we're doing, and this is the progress that we've made, or the roadblocks that we're encountering on this. So just again, emphasizing continuous communication. And then the last one, or number 5, probably one of the most important ones, is being that backbone support. So part of being seen as that chief health strategist is going to be also recognizing that there needs to be an entity who's going to play the role of convening the group. They're going to play the role of potentially keeping records or minutes or notes from the meeting. They're going to be the ones that are going to be setting up meetings, whether they be in person or virtually. All of those pieces that are necessary for the group to function, that somebody has to take on, and that's referred to as the backbone support. And so assuring that through this process of collective impact, we have that entity that is serving in this capacity. Now, in some instances, that may be the health department through its chief health strategist process. In another instance, it may be another partner who is willing to step up and serve in this capacity of backbone support. So hopefully that provides you a little bit of background and a little bit of a foundation on how public health operates, kind of how we've evolved, and how we go about the process of addressing some things. I think there's 1 or 2 more slides that I have here. So looking ahead, this idea of collaborators versus conveners. And I've already mentioned this, that one of the roles of being that chief health strategist is again, not to be the entity that is going to solve the problem, but rather to be the entity that's going to bring a group together to try and solve it. So collaborating, assuring that we're collaborating with all of our partners, and then being able to say, yes, we will be the group that will form a committee to kind of address this problem. So that's what we're hoping to be able to do. Part of that is what we're providing today and sharing the data with you, and then the collaborating part will come as we develop the community health improvement plan, as we kind of develop strategies, and then work within our communities to kind of implement those strategies. So next slide, please. And then the last one is our District Health Department number 10 annual report. And I just want to put a plug in for this. Our annual report is available out on our website, as I believe our previous annual reports. Our annual report provides us an opportunity to kind of showcase and share some of the accomplishments that we have achieved, in this case, over 2021. Now, as obviously a large chunk of that was dealing with COVID, but it was not the only thing that we got through or that we worked through in 2021. So I would encourage you to go out to the website to kind of download a copy of that report. We do have some hard copies, but not a lot. So you can go out there, you can take a look at it. Our annual report is constructed, pretty continuously year to year. So the first part of it starts with just an overview of the agency. Then we kind of move into some divisional highlights. And then the very end of the report, there's some additional 10 county specific data in there. And that's really where a lot of folks like to go to. They like to see where does their county line up with the other 9 counties that make up the jurisdiction. So again, I encourage you to go out to our website. it is listed there, and you can download a copy of our annual report. And if you have any questions on that, you can feel free to reach out to me or to either Aaron or Donna for hopefully we can get you an answer for that. So I believe that's what I have for today.
Hi, everyone. My name is Erin Barrett. I'm a public health planning coordinator with District Health Department number 10.
And hi, I'm Donna Norkley, and I'm a health planning coordinator with District Health Department 10 and staff to the MyThrive.
And we will be taking you through the MyThrive 2021 Community Health Assessment.
So MyThrive brings together a variety of cross-sector partners and residents as well across all 31 counties of northern lower Michigan to conduct a community health assessment and collaborate for community health improvement. Next slide. So the vision of MyThrive is healthy people in equitable communities. And you can see the 31 counties on the map on the right, with our DHG 10 counties in the light blue and the whole 31 counties in both shades of blue. So who was involved in MyThrive? We had 7 local health departments participate, 3 health systems across our region, many community-based organizations, residents, coalitions, and collaboratives, as well as businesses and academia. Next slide. So why did we do a regional 31 county approach? That's a good question, but really it's to maximize our resources mostly, but we also leverage collective wisdom across the region. So we got input from so many diverse partners that helped us strengthen our knowledge about the communities that we were assessing. It also strengthened our partnerships with those partners. And it produced high quality county level data that's comparable across the region. So we can all compare the same data across all the different counties. And we better understand local and regional patterns and helps us align our priorities so we have shared priorities and shared strategies. Next slide. So these are the 4 assessments we used with MyThrive. We used the MAP process, which is the gold standard for completing health assessments, and it's the mobilizing action for prevention and partnership. And one of the first assessment was the community health status assessment, and that is secondary data that we gathered from data other people collected across our counties. And it asks, how healthy are our residents? What does the health status of our community look like? And then the forces of change assessment looks at what's occurring or might occur that affects the health and well-being of our community. So what are some specific threats or opportunities that are generated by these occurrences? So one example is, the COVID pandemic and how it impacted our work as far as health improvement. And these assessments were done regionally. So we conducted 3 assessments, 1 in each region of the 31 counties, the Northwest, the Northeast, and the North Central. The community system assessment, we also did that assessment regionally, and that was different. It looked at how our partnerships, our community organizations are all working together to improve health, and it assessed the organization's system on various levels. The community themes and strengths assessment was where we gathered primary data from residents and healthcare providers, and it asked what's important to the community, how is the quality of life perceived in the community, and what assets does the community have that can be used to improve community health. And we did surveys of community residents across our 31 counties. We also had organizations do small pulse surveys with their clients, and we also surveyed healthcare providers. Next slide. So you can see the great variety of and numbers of people we collected data from for the MyThrive assessment. So for the healthcare survey, we had 354 physicians, nurses, and other direct care providers complete that community themes and strengths provider survey. We had 840 clients and patients participate in the Pulse survey series, and 396 community partners participated in focused conversations for the community system assessment at 28 community collaborative meetings. So we not only did that assessment regionally, we wanted to drill down, and we held focused conversations at community collaboratives in each county to get more local input and data. And then we had 100 indicators of secondary data that we collected from local, state, and national databases. 152 participants in 3 regional community system assessment events, and we had 199 people or organizations participate in the Forces of Change assessment. And for the community survey, out of the community themes and strengths assessment, we gathered information from 3,465 residents. So next slide.
Thanks, Donna. So now I'm going to take us through a tour of how we visualize this data and how we're sharing this data and how you can access this data. We want to make sure that everyone, inclusive of community partners and residents, can access and use this data. So with that in mind, we take a scaffolded approach to sharing this data. What this looks like in form and function is sharing the data in lots of different ways so that everyone can feel empowered to move to action with this data. So we'll first tour the first 4 that you see on this slide. We have data briefs, data snapshots, county files, and regional assessment reports. And currently in progress is our community health assessment reports, which are being produced by local health departments as well as our hospital systems. If you see any additional ways that we can visualize, communicate, and share this data, definitely reach out to us and we'd love to connect with you. So on this slide, this is all about our MyThrive data briefs. We developed 3 topic-based data brief packets, one for each of our 3 subregions within those 31 counties in northern lower Michigan. These data briefs are highly visual, they're color-coded by data source and organized by different priority areas that bubbled up from the data sense-making process. So included in each packet is an assessment snapshot, which provides just a high-level overview of how each data collection method was implemented. There's a navigation guide, which you can see on the right side of this slide, as well as an acronym key. And this data pulls from all 6 data collection methods and organizes the data by topic area. So think like housing, access to care, chronic disease, etc. Specifically, the 10 to 11 key issues or areas that bubbled up in each of the 3 subregion areas. On this slide, you will see screenshots of our regional assessment reports. So like Donna mentioned, we conducted the community system assessment and the Forces of Change assessment at the regional level. So we have both sets of those reports available on our website for you to use. Additionally, we developed 10 MyThrive data snapshots specifically for DHD-10's 10 county service area and for our in-person data tour events. We'll also be sharing these virtually as well if you're viewing this virtual session. So these MyThrive data snapshots are just a sample of the MyThrive data for each of DHD-10's 10 counties, really to give you a feel for the MyThrive data and an introduction to the data in a digestible way. On the front side of these data snapshots, you will see the specific county you're looking at, as well as a sampling of the secondary data indicators that were collected. Again, this was data collected by other sources that we then pulled in for the MyThrive Community Health Assessment. Specifically for this data snapshot, you'll see 11 of those data indicators out of the 100 that we have in the full data set. On the back side of this data snapshot, you will see a summary of our focused conversations. This was within our community health system assessment. And so in addition to those regional assessment for the data collection, we also conducted county level focused conversations. On the bottom half of that backside of the data snapshot, you will see a sample of our community survey data and our provider survey data. This is just a sample. Both of these surveys mirrored each other. So the first question for both the community and provider survey asked about important factors for a thriving community. So you can see that reflected in this section, as well as important issues that are impacting your community right now. I do want to emphasize that this is just a snapshot, so it's really just a sample of the data. And if you want to access the full spread, I'll show you that on the next slide. Additionally, we have made this data snapshot template available, so you can use it and customize it, specifically looking at those secondary data indicators on the front page. So we have recorded a separate session to show you how to customize this data snapshot. On this slide, you will see a screenshot of our MyThrive data files. So each one of the 31 counties within the MyThrive area has a data file. This is in Excel format, and this gives you the full spread of data collected at the county level specific to the county you're looking at. This data is set up to be a little more technical than our data briefs, but really serves as great building blocks that you can slice and dice, combine counties depending on your service area or jurisdiction. So for example, if you're an organization that covers Kalkaska and Antrim County, you could download those two files and review that data and compare or combine those data sets. You can also customize your data snapshot with these data files, or you could also engage in your own data visualization. When we go through a tour of this data file, you'll see we have some simple data visualization bar charts and graphs available, but feel free to change it up depending on your needs. So before we dive into the MyThrive data file tour, I just wanted to highlight the website where you can find all of this data. So it's www.northernmichiganshire, Shire is spelled CHIR.org, and you can go -MyThrive to get directly to the page that has all of this data that we're talking about in this virtual session. So you'll see access to the MyThrive data files, the data briefs, and our regional level assessment reports like the community system assessment and the forces of change assessment. And so I'm going to pivot my screen and bring up that website so you can see what I'm talking about. All right, so hopefully you're seeing our Northern Michigan Shire website. This is the home page. So if you didn't add that -MyThrive, you'll see this navigation panel at the top, and you can click MyThrive, and it's going to take you to the MyThrive overview page. The first kind of half of this page is context, overview, level setting information, takes you through those 4 assessments that Donna took us through. And as you scroll, you'll see that we have data section. So here you can access those 3 data briefs that we talked about. And here, if you click MyThrive data files, you will see all 31 Excel spreadsheets pull up. Once you click on one of these data files, it'll automatically download onto your computer. So I'm going to bring up Mecosta County. So this is exactly what you would see if you were doing this on your computer. This first page, well, first I'll start at the bottom. You'll see many different tabs and they're color coded by data collection method. The very first tab is the cover sheet. So each of these Excel spreadsheets or workbooks has this cover sheet. At the top, you'll see our MyThrive email address. If you have any questions, requests, need technical assistance, or want to bounce some ideas back and forth on how to visualize some of this data or use this data, definitely feel free to reach out to us. But this cover sheet gives you an overview of our 4 different assessments within MyThrive, and then how that data is broken out, and then the specific descriptive statistics for each data collection method. So as you look at those tabs at the bottom, in green will be all of our community health status assessment data. So that's our secondary data indicators that we collected. And for short, we have CHSA. That first CHSA tab will be all of the secondary data indicators, and we're looking at Mecosta County, so that's what we're going to see here. And then you can also see the state indicator and the US indicator. So I'm just going to do a quick scroll, and you can see the full spread of data indicators that we pulled. So if you remember, that data snapshot only had 11 of these indicators out of the full 100. If you toggle over to the next tab titled CHSA Sources, you will find all of the sources for those secondary data indicators. So you'll see the measure name, the description, the data set, the source name, as well as the source link and data year. So perhaps there's a data indicator that interested you, but you don't see any additional ones, but you want to check out that source a little more. You can click on that link and see their full spread of data that they collected. As you move over in these tabs at the bottom of your screen, you'll see CSA in yellow, and that's our community system assessment. So again, this was collected at the regional and county level. Because these are our data files and very specific to the county level data, you'll just find the county level information in here, but on that cover page, there's a link to access the regional report as well. So with these county level focused conversations, you can see the exact questions that were asked during those meetings with community partners. These meetings occurred at human service collaborative bodies, coordinating councils, or local coalitions, and you can see the responses they provided. Additionally, there was a voting element to this data collection method, so you can see the results of how they voted on the right. Moving into the community themes and strengths assessment, like Donna mentioned, we had 3 separate data collection methods within this one overarching assessment. So that's why you'll see 3 shades of blue in the tabs. The first 4 blue tabs in dark blue are for our Pulse survey series, where we had 4 different topics and were conducted in mini client interviews. And so we focused on aging, children, disability, and economic security. So if I were to click on one of these tabs, you will see that patients and clients were asked a set of questions. One was a close-ended question where they had to strongly disagree to strongly agree with the statement provided, and then provide some open-ended feedback to that. And you can see the distribution of responses as well as the qualitative data collected within the Pulse survey series. Moving across into this medium blue, we move into the community survey. The community survey was conducted via online and paper format and focused on community residents throughout the 31 counties. Again, we're looking just at Mecosta County right now, and we split out the community survey data into 2 tabs. So first you can see demographics, and then the actual kind of content in that survey. So if you click on demographics, you can see all of the different questions we asked such as zip code, age, insurance type, race and ethnicity, things like that. So you can see all of that data in here. And you can see the distribution of responses on the right, and then we have some kind of simple bar charts to help visualize that data. Again, if you are interested in data visualization or want a different format for the illustration, take this data on the right in these tables, and then you can re-visualize it into perhaps a stacked bar chart or a pie chart. And toggle over one more tab, and this is where you get into the main questions that were asked in the community survey. So one question asked about factors for a thriving community, so you can see the results of that question. Then we looked at important issues impacting your community. We had a quality of life question. And then we had a question focused on built environment. And then we also had a question asking about assets in your community. So this could have been agencies, organizations, community leaders, things like that. And so you can see all of that information is included in here. With the asset information collected, we did go through and clean that data. So for example, if Reed City Senior Center was noted multiple times in the survey results, we just removed any duplicates. And then the final tab in this data file is our provider survey. So this is set up very similar to our community survey tabs, where you can see the bar charts on the left and then the data distribution on the right. So that wraps up our tour of the data file. There's lots of different tabs, lots of different data that you can use for your needs. Again, if you have any questions on how to use this Excel workbook or need ideas on how to visualize it, definitely reach out to us with that MyThrive email address, and we'd love to connect with you. All right, so I'm going to take us back to the slide deck. Okay, now that we've talked about the data that was collected in the 2021 MyThrive Community Health Assessment, I wanted to talk about different ways we are moving to action with this data. So given 31 counties is a very large area, we break this down into 3 subregions. And within each of those 3 subregions, we have 3 regional cross-sector work groups. One in the Northwest region, which is the dark blue on this map. We have our North Central work group. You can see those counties in green, and then our Northeast work group in a lighter blue. These work groups are co-creating shared goals and strategies to improve community conditions specific to the 4 priority areas that emerged from the 2021 MyThrive Community Health Assessment. All 3 of these work groups are open to all, and there's lots of different ways to engage with these groups. Okay, so once we finish collecting all of this data in 2021, partners and residents gathered virtually at the end of 2021 to engage in some data sense making, which is really a process to kind of make sense of the data, identify different priority areas to collectively move forward with. Data was reviewed at the regional level, recognizing we have a lot of similarities, but we also have a lot of uniqueness to each of those regions as well. There are some priority areas that cut across all 3 regions, and then some that are unique to each region. So here on this slide, you can see the 4 priority areas that bubbled up for each region. And this isn't to say that the other issues and needs are not important, but really an understanding that if we collectively channel our energy towards shared priority areas, we can make substantial change to the system conditions, creating and contributing to poor health outcomes. And also recognizing that these priority areas on this slide are deeply interconnected with different sectors and factors within the system. We all ultimately have the power and influence to create positive community change, no matter what role we have within the community. In addition to our regional work groups who are engaging in collaborative community health improvement planning and efforts, there's lots of other ways to move to action with this data. We want everyone, whether or not you are directly involved with MyThrive, to feel invited and empowered to use this data. So we've listed a few different ways on how to move to action with this data, and this list is not exhaustive by any means. But if you're engaged in any type of grant proposal development, definitely use this data. It's great, especially those Excel data files. That gives you a ton of information to support your grant proposal development. You can also use this data to inform organizational strategic plans or collaborative action plans. You can also support advocacy efforts within a specific topic, such as housing or substance use. And you can also collaborate with others working on similar or perhaps intersecting issues. In addition, you could also identify gaps in the data to strengthen collaborative data collection efforts moving forward. So if after looking at all of this data, you see some gaps or something that might be missing, let us know so we can incorporate that into the next cycle of data collection. And then another way, if you or your organization or collaborative body have any type of community health assessment requirements, you can use this data to support that, or perhaps supplement any existing data that you might have. So there's lots of different ways to move to action with this data, and we'd love to hear how you use this data. Okay, well, that wraps up our virtual session of the District Health Department number 10 Community Summit Data Tour. If you have any questions, please do not hesitate to reach out to us. We have listed the MyThrive email address here, so if you have any data related questions or you'd like to engage in this work, we'd love to connect with you. And then we also have the Northern Michigan Shire website listed here as well. So thank you so much for watching the virtual session.